palliative care. And we will be recorded today. Thank you, Leslie, for someone remembered to hit the record button. And we're going to be giving you information. You will have hopefully received a presenter's guide, the participant guide for Nancy Rodriguez's talk about Alzheimer's and dementia. If you haven't, well, make sure to resend it later. And you should also have an overview of what Lisa's going to talk about in terms of a nice outline about Lisa's talk. And we've planned this to have maybe 2 30-minute talks or so, and then plenty of time for Q&A. So please keep us in mind, keep your questions coming, and you can put them in the chat. And a little bit of housekeeping, if you don't mind putting yourself on mute, at least for the beginning. I will be showing some videos in the presentation that Nancy will be giving us. So without further ado, I'm delighted to introduce one of my dear friends and colleagues, Professor of Pharmacy at UMES, advocate and community educator for the Alzheimer's Association. She teaches about gerontology. She helps train pharmacists, the next generation of pharmacists that are going to be even more customer focused and user friendly and dementia aware. So, and as you take this on and you're here, I'm hoping you can help me and my colleague Leslie Zimmerman with the flowers. She's our constituent manager from the Salisbury office. And we'd just like to help the Shore become a little bit more dementia sensitive, dementia friendly, if you will. So please keep in mind all the things, and we'll tell you more about all that we can do to make that happen. Thank you so much. And Mia Cranford may say a few words as well on behalf of Talbot. And
welcome everybody. Talbot Hospice is very excited to partner with the Alzheimer's Association to bring you this 3-part series. We truly hope that the information that our speakers have provided and are providing will help to answer the questions that you have and will bring you comfort and knowing that you're not alone in this journey. Talbot Hospice offers many programs that can help to make your journey easier. Our palliative care program, which we'll hear about shortly from Lisa Rizia, who is our nurse and educator from Talbot Hospice, is a program that gives you the help you need while you are still seeking curative treatments for Alzheimer's. And our hospice program, which helps you as you're nearing the end of your journey. Let us walk alongside of you through the whole process to help ease the burden caused by Alzheimer's diagnosis. So we really want you to know that we are here to partner with the Alzheimer's Association to make everybody's journey easier in receiving information and what you need along the way. Thank you. Cindy knows I don't like to talk, so she's muted. She's got to come unmuted.
Cindy, you're muted.
Thank you. You're lucky. So we're going to get on with, and Nancy will be presenting for us. Thank you so much, Nancy.
Okay. Whoops. Okay. Can you all hear me?
Yes.
Okay. Hear me?
Yes.
Okay, give me just a second. So today we're going to be talking about Alzheimer's disease. I'm going to define the different types of dementia that are prevalent in the discussion about brain health. And we're also going to talk about specifically Alzheimer's disease, some of the risk factors, the 3 stages of the disease, and I'm going to briefly talk about some FDA approved treatments and some interesting facts about the research that's going on. And then towards the end, we will talk about some of the resources that are available through the Alzheimer's Association and the different organizations that are attending as well. Okay, so let's talk a little about the impact of Alzheimer's disease. Cindy introduced me as an assistant professor at the University of Maryland School of Pharmacy, and we are very focused on teaching people about Alzheimer's disease. So let's see what we know about Alzheimer's. First question is, how many Americans are currently living with Alzheimer's? Is it 850,000, 5.8 million, 12 million, or 3.4 million people? Which answer do you think would relate to how many Americans are actually living with Alzheimer's disease?
I'd say, excuse me, I'd say 12 million.
Okay.
I think it's probably 3.4 million. I mean, is it 3.4 or 314? There's a 3.4. Oh, then I'm going to say 12 because I wanted the bigger number.
Okay.
Susie here, and I would say it's probably 12 million.
Okay, thank you. Okay, so what's the real number? So we currently have 5.8 million people living with Alzheimer's disease. And we project that by the year 2050, that number is going to rise to 14 million. Now, not only am I knowledgeable professionally about this particular illness and dementia, but I also experienced it on a personal level. Probably about 50-something years ago, my grandmother was diagnosed with a dementia, and then 55 years later, my father was diagnosed with dementia. So this is a disease that affects everyone. Next slide, please. So let's talk about some facts. So let's see. Cynthia, is this going to go? Okay. Let's find out what you do know about dementia or Alzheimer's disease. Alzheimer's is a normal part of aging. Is that true or is that false? What do you all think?
False.
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 False. Susie here.
Okay, thank you. So Alzheimer's is a brain disease that causes problems of memory, thinking, and behavior. It is definitely not a normal part of aging. Now, it is typically characterized by memory loss. Some patients will experience some confusion and an inability to think or communicate effectively. Now, I want to point out that dementia side effects or the experiences or symptoms will be different from one person to the next. And I also do want to point out that consciousness and perception are usually not affected. So typically people are awake, they're conscious, but they're unable to communicate or think effectively. So the next question is, people younger than 65 years old can get Alzheimer's. Is that true or is that false?
True.
True. Susie here.
Mm-hmm.
True.
Now, Susie, what age do you think people can be diagnosed with Alzheimer's or dementia?
I would say that they might start exhibiting some of those quirks early in their 30s.
Mhm. Okay, so in some cases, some can develop the disease as early as 35 years old. Interestingly enough, from all the studies that we know right now, there is a thought that the Alzheimer's or dementia can occur even earlier than that, but we are not able to decipher yet how significant the disease is until much later in age. So let's hear from an
Dementia is the umbrella term for an individual's changes in memory, thinking, or reasoning. There are many possible causes of dementia, and Alzheimer's is the most common cause. Other causes of dementia are vascular dementia, which is marked by changes in the blood flow in the blood vessels in the brain. Dementia with Lewy bodies, identified by specific brain changes throughout the brain that include the buildup of a protein known as alpha-synuclein. And frontal temporal dementia, which is marked by brain cell loss in the front sections of the brain or the frontal lobe. Each type of dementia may have distinct characteristics to cause specific behaviors in the individual, but there is also some overlap in behaviors among the types of dementia.
So why is an accurate diagnosis important? It's important because we can try or attempt to treat these symptoms way before the progression of the disease occurs. And in all types of dementia, we want to know whether or not some of the recommendations and approaches to treating them can be done earlier. So let me talk specifically about vascular disease or vascular dementia. Vascular dementia may be due to some small strokes or maybe transient ischemic attacks, blocking arteries. And so some of these symptoms may overlap with those of Alzheimer's disease, although memory may not be affected. What's important to know about vascular dementia is that we can maybe try to manage the prevention of new strokes. So in this particular case, if a patient is diagnosed with vascular dementia, physician might want to include administering antiplatelet drugs or controlling some of the vascular risk factors, such as hypertension or even diabetes. And in some cases, physicians may prescribe aspirin to slow the progression of vascular dementia. If we were to talk about Lewy body dementia, Lewy body is a little different in that there are problems with memory and judgment, but typically the patient may have behavioral changes or alertness and severity of these cognitive symptoms that fluctuate on a daily basis. One thing that's very common in people who have dementia with Lewy bodies is that they experience hallucinations. They may experience muscle rigidity and tremors. What's important about knowing what to do about this particular dementia is that in most cases, the hallucinations are very bothersome and distressing to both the patient and family members. And so we would have to treat this symptom more so than in Alzheimer's disease or vascular dementia. In a patient who has frontal temporal dementia, there is some differences in that most patients who are diagnosed with FTD are genetically, it might be inherited. There's a genetic component behind that. Typically, We have the same symptoms, just like you would Alzheimer's disease and any of the other dementias. But what's most significant in this type of dementia is that speech is usually affected. And there is some difficulty in naming and word finding, which is also another distressing factor. Now, Alzheimer's disease is a combination of all of these symptoms that we talked about. And what happens in Alzheimer's is that there is some destruction of the neurons in specific areas like the front of the brain, the back of the brain, and the sides of the brain, and everyone will experience different symptoms. There is a presence of tau, which is an accumulation of fibers that destroy some of the neurons in the brain in Alzheimer's disease. Okay, next slide, please. Okay, let's hear from another.
More than 100 years ago, Dr. Alice Alzheimer's described specific changes in the brain, what we call the formation of plaques and tangles. Now, Alzheimer's is a progressive brain disease that's marked by these key changes and is thought to impact memory, thinking, and behavior. The brain has three main parts: the cerebrum, the cerebellum, and the brainstem. Each one plays a role in how the body functions. The cerebrum fills up most of your skull. It is part of the brain most involved in remembering, problem solving, thinking, and even feelings. There are about 100 billion nerve cells or neurons throughout the brain that transmit messages in order for us to create memories, feelings, and thoughts. Alzheimer's disease causes nerve cells to die, which leads to the brain tissue loss, or what we call shrinkage, and causes loss of function and communication between cells. These changes can cause the symptoms of Alzheimer's disease, such as memory loss, problems with thinking, planning, behavioral issues, and even at the end stages, problems with swallowing.
Okay, so let's talk about risk factors. So give me just a second here. Let's see where we are. What is the greatest known risk factor for Alzheimer's disease? Is it genetics? Is it family history? Or is it age?
I would say family history.
Okay. Anyone else?
Genetics, actually.
Okay.
Susie here, sorry.
Okay, thank you, Susie.
And wouldn't genetics and family history be kind of similar?
That's what I was thinking, actually.
Okay.
We have age in chat as well.
Any comments? Okay, so typically age is the biggest risk factor for Alzheimer's disease. So keep in mind that dementia and Alzheimer's is not a part of normal aging, but we are getting older. And the older that you get, the higher the risk is for Alzheimer's, and it doubles every 5 years. Statistics indicate that there is about 32% of people age 85 and older who have Alzheimer's or some sort of dementia. I want to ask you, do you think that there are gender differences in Alzheimer's disease? Is it different for men versus women? Who do you think may have a more prevalence of dementias, men or women? Any comments?
I'd say equally. This is Gretchen Guthrie.
Okay, thank you, Gretchen. Any other comments?
I think I've heard
What do
women.
you think? Okay, so to answer that, more women tend to have Alzheimer's disease and other dementias. But in actuality, when we further analyzed the data, we found out that there's absolutely no difference between men and women. What we have discovered is that women live longer on the average, more so than men. So therefore, there is no significant difference by gender. Women are not more likely than men to develop dementia at any age. How about education? Do you think that education makes any difference in the presence of dementia or Alzheimer's disease? Okay, Robert says yes. Any other comment? Okay, so again, studies indicate that people who have fewer years of education appear to be at higher risk than those with higher education. It's thought that maybe that cognitive reserve that we have to better compensate for changes in the brain can cause Alzheimer's disease or dementia. Does race have anything to do with presence of dementia or Alzheimer's disease? Any thoughts on race? Is it different for Caucasians, African Americans, or Hispanics?
Susie here. I don't think there's any difference, really.
Okay. So in actuality, there are more older African Americans and Hispanics more likely than Caucasians to have Alzheimer's disease or dementia. But why? Because they are more prone to have conditions such as high blood pressure and diabetes and lower levels of education and other maybe socioeconomic or financial characteristics. So one thing that's very, very important is that in these populations as well, there's more of a suggestion that misdiagnoses are common in these populations. And that could be for numerous reasons. Maybe they're not going to the doctor as often, maybe due to disparities in health. Maybe they're not able to manage high blood pressure and diabetes. Education may be a factor. So there are a lot of factors that are evolved in whether or not race plays a part in dementia. So let's hear from the expert.
Alzheimer's disease is marked by specific brain changes that result in the clinical changes in individual experiences. That is, changes in memory, thinking, or reasoning. And ultimately, Alzheimer's is fatal. The exact cause for these changes is unknown, but there are some hints as to what may contribute to an individual's risk. Age is the greatest known risk factor for Alzheimer's. And when we look at populations of people, we see an increased risk over the age of 65. However, Alzheimer's is not normal aging. Family history is also a known risk factor. Research has shown that those who have a parent or a sibling with Alzheimer's are more likely to develop the disease, and that risk increases if more than one family member has Alzheimer's. When we talk about the genes involved in Alzheimer's, there are two categories that could potentially be involved: risk genes and deterministic genes. Risk genes increases an individual's risk for developing the disease, but does not guarantee that they will develop Alzheimer's. Deterministic genes, which are rare for Alzheimer's, guarantee that the person will develop the disease.
Okay, so there's some interesting data about the populations, and as we talked about a few minutes ago, again, there are a lot of factors in why there are certain populations at higher risk. Next slide, please. So let's talk about the different stages. First of all, does everyone living with Alzheimer's experience the same early symptoms? What do you think?
I would say no.
Okay.
Susie here, no.
Mhm. Okay, so we're going to share some stories of different types of symptoms.
Kind of forgetting. It really, really is. It's not just forgetting where I put my car keys. It's much deeper than that. And for example, I cannot read a book. I used to be a voracious reader because by the time I turn a page, I have forgotten what I had read. And if you're reading a novel, you have to know what transpired before it in order for you to continue to read on. And so I can't read a novel. So I've even stopped trying.
I'm like an overachiever. And when you're unable to deliver or you're not performing at the same pace that you once did before, that's frustrating. It's frustrating to not know where you place things. It's frustrating to not be able to explain to someone the problems that you're having. You can't articulate it in a way. It's frustrating to read something and you forgot what you read. It's frustrating to continuously have to change your password and you just changed it last week and you're constantly doing the same thing over and over again.
I think the thing that surprises me the most about my dementia is that it is progressive, and I'm finding that I'm forgetting more. And they do memory tests for me all the time at the doctor's, and so that becomes a little disconcerting at times to see my cognitive impairment continue to decline. But again, I really have hope. I don't live really in the future. I can't live in the future. I can't worry about what the future is going to bring. I have to live for today.
So what does living with Alzheimer's feel like? I have to say that from understanding the disease progress, the most frustrating part of dementia and Alzheimer's disease is in the very beginning when you're starting to realize that you're losing control of how your brain works. In the middle stages, patient may not feel all that distressed. It's frustrating, but your memory is lost. There is not a very significant change in that person's thought about the disease. So mild disease in the beginning, again, the disease can be mild, moderate, or severe. It's very distressing in the very beginning. And then at the very, very end, where the patient starts to lose the capability to be able to speak, to walk, to feed themselves. And so this is where palliative care comes in, where not only does the patient need support, but the family as well. Next slide, please. So let's hear from another expert.
Alzheimer's affects everyone differently. As a result, it's difficult to place a person in a specific stage of the disease. However, there are 3 general stages that are commonly referred to as early, middle, and and late-stage Alzheimer's. In a medical context, you may hear these stages referred to as mild, moderate, and severe. In the early stage of Alzheimer's, an individual may be able to function independently. However, they may start noticing more frequent memory lapses. Friends and family may also begin to notice difficulties in the person, and a healthcare provider may be able to detect problems in memory or concentration by conducting a detailed medical interview. Middle stage Alzheimer's is typically the longest stage and can last for many years. Damage to the brain cells can make it difficult to express thoughts and perform routine tasks, and this can lead to increased feelings of frustration and anger. In the final stage of the disease, an individual loses the ability to hold a conversation, control their movements, or respond to the environment around them. Cognitive skills, that is, their memory, thinking, and reasoning skills, continue to decline, and this can lead to personality changes and need for round-the-clock care.
Okay, so let's talk about the FDA-approved treatments for the symptoms. Let's test your knowledge first. Now, there are presently several drugs available to slow down the progression of Alzheimer's disease. Is that true or is that false? What do you think?
Susie here. It may help control some of the different episodes that someone might be having.
Okay. Thank you, Susie. Any other comments? Okay, so what's the answer? Okay, there's currently no treatment to prevent, treat, or slow Alzheimer's disease. However, there are several drugs that are used to address some of the symptoms. There are different types of symptoms, cognitive symptoms and non-cognitive symptoms, and also functional symptoms. So when we talk about the cognitive symptoms, we're talking about the inability to use or understand words, the inability to recognize objects or sounds. It's kind of like the basic symptoms that are going on with your brain, the cognitive part of your brain. But then in addition, patient may experience non-cognitive symptoms, which are treated differently. And these can include depression. Patient may feel that anger or irritability. They may experience the hallucinations or the psychotic symptoms, or they may start to get so agitated and aggressive that we need to treat these behavioral disturbances that may occur. And then lastly, the functional symptoms need to be treated. And that's typically the very last stage. It's included in that last stage where the patient will have an inability to care for themselves completely. Next slide, please. So let's hear.
Currently, several drugs are FDA approved to treat the cognitive symptoms associated with Alzheimer's disease. They treat the symptoms, but they don't treat the underlying cause. So eventually people will progress, but they do treat some of the symptoms and help people for a time. So the first class of drugs are cholinesterase inhibitors. These drugs work to prevent the breakdown of acetylcholine, which is a chemical messenger found in the brain that's associated with learning and memory. There are 3 FDA-approved drugs that are in this class of drugs. There's Aricept, there's Exelon, and there's Razidine. There's another class of drugs that's modulates glutamate, which is another chemical messenger in the brain that's associated with learning and memory. And this drug is called Namenda. And then there's a final class, which is actually a combination of cholinesterase inhibitors and glutamate modulator, and this is called Namzaric.
Okay, so let's talk a little about Aricept, Exelon, and Razidine. You may know these particular drugs by their generic name. Aricept is now marketed generically as donepezil. Most of these medications in this class, the cholinesterase inhibitors, have sort of the same side effects. So donepezil, rivastigmine, which is another word for Exelon, the brand name Exelon, and Razidine, which we do not use as much anymore. It has more significant side effects than the donepezil and the rivastigmine. But this first group of drugs have side effects such as insomnia. The pulse may drop, so we have to be careful about giving these in the morning. It's typically advised to give the donepezil, especially in the evening, to avoid falls. But these cholinesterase inhibitors may have side effects that are generic, may cause diarrhea, in some cases headache. It is not recommended to crush any of these medications. The donepezil can be given with or without food. There's no significant difference. Rivastigmine, however, or Exelon, is recommended to be given in the morning with breakfast and in the evening with dinner. Rivastigmine, out of all of them, rivastigmine or Exelon is available in a patch. So if a patient refuses to take medications orally, Exelon or rivastigmine can be prescribed instead. Now let's talk about Namenda. Namenda is now marketed generically as memantine. It is a glutamate modulator. It can be given with or without food. It can cause dizziness, headache, or constipation. This particular drug and all the other ones, the Aricept, Exelon, and Razidine as well, have to be tapered. And what I mean by that is they're usually started at a low dose and then increase slowly. And the reason we do that is because we don't want the person to experience side effects, significant side effects, so that they stop taking it. So it's really recommended to start slow and go higher within a couple of weeks or even a month, as in the use of donepezil or Aricept. The last FDA-approved drug I want to talk about is the Namzaric. And this Namzaric is a combination of the donepezil and the Namenda. That combination is usually prescribed to be given once a day. It's an extended release, and it's usually prescribed in the evening. Now, we may not be familiar with this because some insurances may not cover it. It is effective for people who have issues with compliance because, you know, you're decreasing the pill burden, but insurance companies will not pay for it because Namzaric is a little bit more expensive than the generic of donepezil and memantine together. Let's go to the next slide. Okay, so as a refresher, there are 3 types of drugs that are approved: the cholinesterase inhibitors, the glutamate modulators, and a combination of these medications. Typically, the combination therapy is recommended for that moderate to severe stage. So a patient may be started on a particular medication, and then we may add memantine as the disease progresses. That's typically the most common treatment approach. Let's talk a little about advancing Alzheimer's research. So there are a lot of other investigations going on. We do hope that in the next few years that some of these studies are fruitful. Let's start with investigating that early
An
intervention.
incredibly exciting time in Alzheimer's and dementia research. The advancements that we've made in the last decade to understand the disease as a continuum, meaning that the biological changes are starting a decade or more before someone is experiencing the changes in the memory and thinking. This sets the stage for possible prevention. The idea that when we have the tools to identify those individuals at the earliest time point, and when we have the interventions to target individuals at that earliest time point, we can intervene to stop or slow the progression of the disease before an individual loses their memories.
I'm excited about what we're learning these days regarding lifestyle. One of those things that we've seen in the past of things like exercise and nutrition have now started to gain more momentum to indicate to us that it can change your ability to slow cognitive decline. That is really the first stages of Alzheimer's disease. This may include things like social engagement, mental cognitive training. It can be things such as exercise. It can be nutrition. All those things are now starting to point that they will lower your risk for Alzheimer's disease.
Okay, so and when we talk about managing brain vascular health, this is very, very important. That includes making sure that people who are diagnosed with high blood pressure are monitoring their blood pressure, that they're keeping their blood pressure, sugar levels, cholesterol in check. That is a really important point because vascular health plays a really important, significant role in the progression of dementia. Some physicians are going to adding aspirin at a low dose in people who have significant brain vascular disease. As the speaker pointed out, it is very important to stay physically, mentally, and socially active. In actuality, the only proven recommendation that would slow the chances of dementia is staying physically, mentally, and socially active. And in addition, I don't want to go away without talking about maintaining a healthy lifestyle with a low-fat, low-cholesterol diet, rich in dark vegetables and fruit, and maintaining body weight. Okay, so here are some resources for the Alzheimer's Association, the phone 24/7 helpline, 100-272-3900. Cynthia, if you wanted to add or go on with the key resources, please.
Sure. Sure. I think what we'll do is in an effort to save time, we'll just see what questions come up, and then maybe when we wrap up, I'll share with you a few of our upcoming programs that we have. And Nancy, I can't thank you enough. This was such a great presentation, and thank you all for your patience. It's not an easy system to advance or correct. And you could see I got ahead of Nancy just a couple of times, and I didn't want to foul up going backwards because it's just not it's not linear, if you will. But thank you, Nancy. We did a very good job remotely managing all of that. And I hope you found that it was useful and some helpful information. And I can't thank Nancy enough for teasing out some of that specific information about the pharmaceuticals. There is more hope, I believe, on the horizon than this video, than the last slide was telling us about. You know, with particular, Nancy was mentioning the vascular health. Really, we found research in 2019 that said, really, we want to be aggressively treating our blood pressure. And just doing that alone and giving doctors, they gave doctors ability to do so with however they wanted to do it, you know, diet, exercise, and or drugs, you know, however they want to do it. They reduced about 19% of people getting mild cognitive impairment. So that's a huge reduction in a precursor for, you know, dementia or Alzheimer's disease. So if we can eliminate 20% of the population by treating aggressively, you know, just more aggressively treating blood pressure, that would be really helpful. I wish they had done that for my dad. I think he was one that we watching his blood pressure for a good 5 years. You know, we may see that people of my generation aren't going to be watching their blood pressure. Their doctors are going to be more actively managing it. But now let's get to Lisa's part of the program. So Lisa, if you want to take over, and if you'd like me to, I could try to pull up your slide, or we can just have faces too. It might be nice to just leave it at faces.
Faces is fine with me. Okay. I did have an outline of my presentation that you all can access. I don't know if you may have been able to get that ahead of time or not, but my part of the presentation today is to really dive in and look at the hospice and palliative care services that are available for families and patients that are impacted by Alzheimer's and dementia. I want to stress the importance of early intervention with both of these models of care. Certainly, as we introduced today's topic, we talked about Talbot Hospice's motto is to know us before you need us. And that truly is a resounding statement, especially for patients and families that are impacted by dementia. I think if we can, as a people, start to really try to focus on helping people with that early intervention, we'll see a lot better outcomes, a lot of increase in individuals and families' quality of life. So I'm going to start with a personal story that I titled "Time is of the Essence." Kind of goes along with this, and it's about a husband and a wife. It's a true story, but I'm going to change their names and change a few of the details. But I just want us to, as you hear this, just think about the timeline here and how important intervention can be. So we have Clayton and Jan. They have been married for 60 years. Jan has been experiencing symptoms of dementia, Alzheimer's, only probably for the last 3 or 4 years that others around her could note. Now, that doesn't mean that Clayton and she didn't know that things were changing on the home front more. I don't know that piece. But I do know that her functional status had changed considerably. But when you look at the stages of dementia that Dr. Rodriguez-Weller just shared with us, she certainly was still in early to mid stages when this occurrence happened, but depended more and more and more on Clayton for herself to be able to manage life. And in January of this year, they both came down, they contracted COVID. So, you know, that's impacted all of us over the past year. In this instance, they were both at home. Prior to this, you know, they were able to be out some. Jan could go with Clayton, you know, to visit different people. And I think, you know, that had been ongoing. Anyway, they got COVID. They were home. And he began to have some symptoms that caused him to deteriorate rather rapidly. And one evening he went outside for something and she didn't realize he was outside. She locked the door and went to bed. He fell, and he was outside for about 3 hours before neighbors heard him hollering. So, you know, these individuals are late 70 to 80 years old. You know, a fall is a traumatic occurrence, but he had COVID. He ended up in the hospital with, had probably caused his fall a slight MI, and now had pneumonia due to the COVID. So he's hospitalized here in Easton. It wasn't long though before Jan's situation was continuing to deteriorate, not only because of COVID, but because Clayton wasn't there anymore. You know, their 3 adult children were helping take care of her and doing a great job, but it wasn't long. Within that week, she was hospitalized as well. So there we are, both of them in the hospital, but separate. And, you know, no one could visit. And for her, that just started, you know, the ball of deterioration. So they were in the hospital for a period of time, and then they were transferred to a rehab setting in Salisbury, again, separated from each other. And again, family not able to visit them. So, you know, things began to spiral. Clayton did show signs of some improvement, but not Jan. So after several weeks, they were transferred to a nursing facility in Cambridge, which is the town where they live. A positive piece of the story is that they were in the same room. So what a blessing that was, because at least Jan could have the presence of her husband Clayton with her, but her condition was just, you know, she had gone from an early to mid stage to, if I were to have seen her for a hospice evaluation, I would have said she was late, you know, end stage. She was end stage that quickly. And within a short period of time, she passed away. He was able to return home about a week after her death. You know, for me personally, as a hospice nurse, a positive piece of this is that they were together. And I would truly believe that she knew he was there, even though, you know, she couldn't communicate with him at the end. And the children had gotten to visit at some point, but very limited. But I want us to just think about thinking of that story and how quickly things change. Now we know COVID was probably a huge factor in this, but other things change our lives and the trajectory of things, you know. And if we think about the early access to palliative and hospice care in situations, you know, there were instances along that short-lived path that maybe I thought when they were in Salisbury, it was time for hospice, because as I'm going to speak, hospice can be in nursing facilities, but it didn't happen. And it didn't happen when they were, you know, in the final place. And I do believe, you know, oftentimes we miss those opportunities. So I think the goal of my talk would be for us to see the differences between palliative and hospice care, and also to think about the need for early intervention and the ways in which these two models of care can improve the quality of life, not only for the person impacted, but, you know, the person who has the disease, but the family and caregivers of them, because that burden of care is so large. And if families had the support of palliative and hospice care, that could be, you know, that burden could be eased, and that that end of life could hopefully have a more peaceful and rewarding, I would want to say, ending. First of all, I'll talk about the two models of care. So we have palliative care and hospice care, both of which we offer here at Talbot Hospice. I'm going to just introduce those two and kind of show you there's some things that cross over that are similar and a couple differences, and then I'll kind of get into each one, talk a little more in detail. So palliative care is a specialized medical care model where individuals have to have a chronic life-limiting illness. Basically, you know, any chronic illness is going to be life-limiting at some point in time. But if we look at dementia and Alzheimer's and think about that, you know, it begins to impact an individual's life much earlier. So we don't have to wait until someone's at the end of their life to seek out palliative care. That person may continue to seek and utilize curative care measures, you know, so they can receive the support services of palliative care and still be seeking treatment per se. We know it's not curative in regards to dementia and Alzheimer's, but hopefully, you know, they can still seek out things. It is a multidisciplinary approach. So our program here, we have a nurse who oversees and manages our program, and nurse practitioners, a couple of them make home visits. Our palliative care program is home-based. Some are clinic-based, which would mean you have to take an individual to that clinic. Our services come to wherever you call home. And I think that's fantastic, but because oftentimes taking someone who has dementia and Alzheimer's out of their surrounding is going to cause things to be harder on them. So our nurse practitioners will come to, you know, an individual's home or to a nursing facility to see them. So that multidisciplinary approach can also include social work. We have our PharmD who will help out with medication recommendations. Sometimes we use the spiritual aspect as well. And the model of care is to reduce pain and suffering. So moving over to hospice care, that model has some differences. Usually, a person has to have a life-limiting diagnosis with a prognosis of 6 months or less. And when I talk about hospice a little more specifically, I'm going to talk about the importance of hearing that a prognosis doesn't mean a person can only receive hospice services for 6 months. That's a big, big factor. You know, we have patients sometimes who are on hospice for a year or more. We would rather, again, have you come to us earlier and maybe need us less, so that when you need us more, we have built up that trust and that rapport to help with things as the disease progresses. But we do have to have a prognosis of 6 months or less. And the care measures certainly are for quality of life and the reduction of pain and suffering, just like palliative care. But the focus of care switches from life prolonging or curative to control of symptoms and comfort measures, quality of life. And again, hospice is a multidisciplinary approach, and I'll talk a little bit more about that when I delve into hospice care. So you can see there's a lot of overlap, but there's differences. And a great piece about having a palliative care program and a hospice program together in an organization is that our palliative care can identify patients and families that maybe are ready for hospice. And maybe that helps us to provide an earlier intervention. We've really grown a lot in that over the past couple of years. So a lot of pluses to having both programs together. Okay, so timeline for palliative care services. There's not a set timeline for palliative care. Where I mentioned hospice, you have to have a 6-month prognosis. That's not the same for palliative care. People can reach out for palliative care, you know, much earlier in a chronic disease. So much earlier in their dementia, they could seek supportive services from palliative care. And our palliative care team works with their community providers. So there you have, you know, recommendations from our nurse practitioner going to the patient's personal provider to try to, you know, improve their care needs. I've already spoken about the settings for our palliative care. It's home-based. Some programs are clinic-based. The referral process, we receive referrals from physicians' offices, but a family member or even a patient could refer to our services, and then our nurse would reach out to their personal provider to get the official referral. But you don't have to wait for the doctor to make that call. The family can do that. So things can get started much earlier. So some of the benefits to early access of care, and I've already mentioned the improved quality of life. That's from having a team to support you. People aren't alone anymore. Our nurse, Jenny, makes phone calls on a regular basis just to check in on patients and families. And in making those routine phone calls, that might be how she discovers that somebody has started on a decline. Maybe they didn't call her, but she's able to catch that. And then our nurse practitioner goes out and make a visit. And then maybe that individual has deteriorated, as my story talked about. Miss Jan, in that very short period of time, she went from early to middle stage dementia to end stage. So our nurse practitioner then can see this happening, and then maybe they make a hospice referral. So it's there's that team approach. Areas of symptom management that palliative care can help with, as Dr. Rodriguez-Weller spoke about, anxiety and agitation, those things, impact a person's quality of life often early on in the disease. So if we're involved in their care, maybe we can make recommendations to help with that, whether it be medicine or something else. There's more ways to help someone. Pain. Oftentimes pain is so misdiagnosed with our dementia and Alzheimer's patients because, number one, they may start to lose the ability to actually put that into words, or maybe they're having the pain but just not focused on it. Maybe our nurse practitioner picks up on that. That in and of itself, to have something help with pain, can help a person's quality of life immensely. Medication teaching and medication management. As we get older, many of us start taking medications, more medications and more medications, and there's polypharmacy, and people don't, having the benefit of a doctor of pharmacy, which we do on our teams, is so beneficial, because not only do we, as the nurses and nurse practitioners and physicians, learn from his wealth of knowledge, but then we can teach our patients and families. We can look at maybe this medicine's interacting with that medicine, causing more problems for the patient. Sleep pattern problems. If we don't sleep, things get worse. And if the patient's not sleeping and their loved one or caregiver can't rest, there we have again that snowball effect of problems. So our palliative care program can help recognize problems and try to help manage them. Certainly gastrointestinal problems, constipation, nausea, vomiting, they can make recommendations. Having a palliative care provider visit patients and having the availability of families reaching out to us reduces ER visits and readmissions to the hospital. And that is a huge, patients with dementia, to take them out of their environment to the emergency room and be hospitalized, that is, can be catastrophic. As I just gave a story that really showed how, how that changed probably the course of her life. So that's a big help. Certainly our palliative care team works with community resources and can help our patients and families, maybe reach out to the Alzheimer's Association. Maybe they haven't had a connection there. Home health referrals. Oftentimes some of these individuals would qualify for home health services. Like I've spoke about the ongoing education about meds, but certainly helping families to understand signs and symptoms of disease progression and what might happen next. and how do we handle what happens next. And what does that do? It decreases the stress and anxiety for the caregivers and families. And that is such a huge help as well. End of life discussions and advanced care planning. That's a great service that our palliative care program can offer. You know, I mean, I'm going to be 60 years old this year. I just recently, and I should have done it a while back, but I have my advanced directive done, and I have made decisions so that my husband or my children don't have to make that for me, hopefully, you know. And again, having those conversations ahead of time. There's that early intervention. Know us before you need us. Do it before you need it. So our nurse practitioner helps with that. And that is a huge benefit. It helps especially when patients transition to hospice, if those conversations have been able to have started prior to us coming on the scene. Our palliative care team has monthly, what we call interdisciplinary team meetings. So they meet as a team to discuss their patients and their needs. And again, you know, there can be identified reasons to bring in our social worker or doctor of pharmacy. Another big benefit of our palliative care program has been our Pathways program, which offers our volunteer program. And COVID has really impacted that. You know, COVID's impacted so many things in our world today. And we look at, you know, what we do here at Talbot Hospice and the wonderful volunteers that we have and the wealth of things that they can do for us. And, you know, last year it really shut it right down. They're starting to be able to come back to do some things for us. And they have been doing phone call support during this time. So that's huge. It gives, you know, if somebody can build up a relationship, even if it's by the phone, you know, if somebody's socially isolated, trying to care for a loved one, and they get a weekly phone call from a volunteer, how, you know, how important can that be, and how much of a stress relief that can be. And they know they have someone to vent to. But hopefully in the coming months, we'll see our volunteer program be able to, you know, come back to more as it was prior to COVID, where our volunteers can go into the homes and offer that in-person support for not only our palliative care, but our hospice patients. So that's a overall view of palliative care and the benefits that it can offer. Now I'm going to switch gears a little bit to talk about hospice services for our patients and their families. And I want to say one thing before I get started is that, you know, often when we think about hospice, many people still think that hospice is only for people who have end-stage cancer or even end-stage heart disease, end-stage lung disease. You know, oftentimes dementia and Alzheimer's patients can get overlooked. So we really have to educate and help people realize that, as Dr. Rodriguez-Weller said, you know, dementia and Alzheimer's is a progressive disease, and it is an end-stage disease, but we want to bring our services to help those patients and families as well. So education, education, education is a huge piece. And that's part of our job here at Talbot Hospice. But now it's something that each one of us can work on, you know, personally, sharing whatever you learned today. I know I've learned things, even though I've been a hospice nurse, I've learned things from Dr. Rodriguez-Weller that I'm gonna share with others. So please share what you learn, and that's how we can spread the word. So eligibility and prognostication, you know, I talked about the referral process for palliative care. Hospice care, an individual does have to start with that prognosis of 6 months or less. That doesn't mean that a person can only receive hospice for 6 months. And when we talk about dementia and Alzheimer's, you know, we identified those stages, that FASC score. And if you look at the eligibility on paper for a patient with dementia, it says stage 7. Well, stage 7, there's the ability to speak a half a dozen words a day, maybe. One word at a time, maybe. Person's not able to ambulate, can't set up without assistance, maybe can't hold their head up or even smile. We don't want to wait until we're there for somebody to come to hospice. And if we paint the picture of that person's disease progression, we can offer them hospice a lot sooner. So we want to delve into the individual to show, you know, their individual progression, to show who they were and what they could do to where they are and what they can't do, and bring that to our hospice medical director. We bring the patients, kind of like their portfolio, we bring their information to our medical director and they look at that. So if a person has comorbidities, that certainly increases their chance of being hospice eligible much earlier. You know, we have a census right now of 44 here at Talbot Hospice, I think, and we have multiple patients with a dementia diagnosis. But if you took all of them and you looked at their picture, everyone is different. Some of them may not have many comorbidities, so they would probably be further along in their dementia for us to be able to serve them with hospice. But many of them have other things that help make them appropriate for hospice care at a much earlier stage. So I'm going to talk a little bit more about how we can look at that. But remember, it's individual, and there's no cut and dry picture of a patient with Alzheimer's dementia for hospice, because we don't have to just look at what stage 7 says. We can look at 5 and 6 and look at that whole picture and hopefully bring hospice care a lot sooner to a patient and family. But a referral and that early, the prognostication, we do have to come up with a diagnosis of 6 months or less. It has to be a certification from our hospice medical director. Oftentimes a patient's provider will give us that referral, but the same thing, a family member could initiate that as well. And then we would contact the patient's provider. Talked about settings for palliative care. Hospice care is provided wherever a patient calls home. So in many instances, that is a patient's home. It could be in a hospice facility. We have a 12-bed residential hospice facility at Talbot. That could also be in a long-term care skilled nursing facility or an assisted living care facility. It could also be in the hospital. That would be a general inpatient care, a different level of hospice care. So most of our patients are in what we call routine home care in one of the settings that I've talked about. We have many patients in the assisted living setting or the skilled nursing facility that have the dementia diagnosis. I think we're missing a big population there as well. So I talked about that stage 7 as a FASC score for hospice. But again, we look at more than just that. So we would gather information on a hospice referral and look at the past 6 months to see, has that person experienced a fall or multiple falls? Because that increases their eligibility for hospice. Have they been to the emergency room or been admitted to the hospital? Have they had documented unmanaged pain, the recurrence of infection, history of urinary tract infections? Oftentimes, you know, as we age, we're more prone to infection. Frequent urinary tract infections affects the whole person so much. And if someone has been to the ER, had falls, had UTIs, and maybe are earlier in their dementia, If we can show that, then we could bring them on with a dementia diagnosis, probably, if they wanted to focus on comfort and quality of life. So, we look at those things that are supportive of the end-stage diagnosis. We can also look at the occurrence of certain problems in that 6 months prior. So if somebody had experienced a pneumonia, especially an aspiration pneumonia, as Dr. Nancy Rodriguez Weller spoke about the change in the swallowing ability. If somebody's been hospitalized for aspiration pneumonia, we should have a red light that there's some change going on there. Recent kidney infection, and I spoke about that. Sepsis. If an individual has a pressure ulcer, breakdown of the skin, normally stage 3 or stage 4, but if individuals start to show signs of skin breakdown, we don't have to wait for a stage 3 or 4 wound to really help support them being eligible for hospice. If they have had a recurrent fever after treatment with antibiotics for an infection, if they can't quite kick that infection, that's showing you, because dementia is a progressive disease that affects the whole person and the whole body. So if I've had a UTI, been treated, and then I get a fever again, that's supporting the evidence that I am progressing. Oftentimes, if a person's had a 10% weight loss in the 6 months prior to referral, that helps them be eligible for hospice care. The weight loss, we look at where a person was 6 months ago, and when we get the referral, if we have that information, sometimes that can be the thing that really helps validate the appropriateness of the hospice referral. If a person is still more functional, there's a diagnosis called sarcopenia that may be their hospice diagnosis supported by dementia. So you can see that we can get creative here to show the eligibility. And again, if someone has multiple comorbidities, so if an individual has dementia, they have diabetes and they have heart disease, and again, we know that that might be the cause of their dementia, as we talked about earlier, that continued high blood pressure and the diabetes. So now we've got a vascular system that's really out of whack. But if we can document that and present that as part of a person's eligibility plan, we can bring them on earlier. And that goes with chronic kidney disease, COPD, respiratory disease, neurologic diseases, liver disease. So pretty much anything that's chronic. So we want to gather the information, and then we present that to our hospice medical director. And if a patient and their family has come to a place where they don't want to seek life-prolonging treatment, they want comfort and quality of life, then we can hopefully bring them on hospice services wherever they call home. So what are some of the benefits of access to early hospice care? And again, this overlaps our palliative care program as well. Certainly, we can help with anxiety. We can help with agitation, help. And again, the focus may be different now, because if an individual was on palliative care and still seeking some life-prolonging measures, we may not do some of the medication things that maybe we would do on hospice care. We look at where they are, but what their family and they want to. It's all individualized. So anxiety, agitation, pain, again, if an individual is suffering from pain and that goes unmanaged, their quality of life is so impacted and so diminished. And again, having our Form D to help us manage those symptoms has been just wonderful. I've been a hospice nurse for a lot of years, and I think back to when we didn't have that piece in our hospice team. And I think of some of the patients I took care of. Now, we did the best that we could, but I think now, gosh, if they were my patient now, I think we could have, we could have managed this sooner and we could have managed this better. but we are where we are, and we have that huge benefit to our team. Wound management, a lot of times people might be bedridden and they may have developed wounds. So our hospice team can help manage those wounds. We may not be able to heal the wounds because, as we've talked about, a person's body is starting to not, they don't have the reserve to heal, but maybe we can keep them from getting worse. Maybe we can keep them from getting infected, and we can help the families take care of them properly. Hospice can bring in durable medical equipment. So if a patient's been in a queen size bed at home where it's hard for their loved ones to, provide the hands-on care they need because now they're bed bound, we can bring in a hospital bed with an air mattress so that helps their wounds not get worse. We could put in a little bedside table so that they can put things there to help take care of their loved one. If they're able to be transferred to the chair, we can get a wheelchair. Oxygen if they're having trouble with their breathing. So lots of things like that. Again, the medication oversight and education, that's part of what we do on every visit for our nurses. They do a med reconciliation to make sure that what we've got as the plan is what's being given to the patient. And that's very important in all diseases. A huge piece, as we talked about in palliative, but I think as dementia and Alzheimer's progressive, this becomes even more of a benefit, is the caregiver support and stress relief. Again, oftentimes that primary caregiver is maybe doing this alone or with intermittent help, and they need to be able to be the wife, to be the husband, to be the son, to be the daughter sometimes, and not just the caregiver. So that's part of what we do as a hospice team, is allow them to be who they are in that relationship with the sharing of some of those responsibilities. And that in and of itself, I think, helps their quality of life and their loved one, the patient's quality of life. So the caregiver support is huge. We also do a lot of teaching to help family members be able to take care of their loved one as their disease progresses. Maybe mom was able to get up, now mom's bedbound. Maybe she was still able to help turn, and now we have to turn her. Now she's incontinent. How do I change mom in the bed? So just things like that. Hospice offers alternative approaches to care as well. I've talked about medication management, symptom management, but we're not just about the medication. We're about the whole person. Hospice looks at the whole person, the physical, the emotional, the mental, and the spiritual. So some of the care approaches that we can offer might be massage, maybe music therapy, maybe art therapy, and depending on where a person is in their disease trajectory. And again, that team approach. Our hospice team meets every other week as a team to discuss our patients, their needs, and where we are with things. And what does the hospice team look like? Well, we have a medical director, a physician, and then we have other physicians on the team to help with our 24-hour, we're on call 24 hours a day as hospice. So we have our physicians, we have our nurses. The nurses are on call 24/7. We don't come into the home and stay. Our care is intermittent, but we're available to the patient and their families 24/7. Our social workers, they bring such a wonderful amount of support and knowledge to our patients and families and help with many different things. Our spiritual counselor, she helps in so many ways. And again, we're not just speaking of, a person, we're not there to, doesn't have to be religion. We're talking about the spiritual aspect of an individual. Our hospice aides, they can come into the home and help provide that hands-on care, help the family members take care of their loved one and show them how to do the things they need done. Our hospice aides are such an essential part of our team. their relationship with the patient is the most intimate relationship that exists in hospice. You know, they're the ones that are at the bedside, that are by a person's side, that oftentimes an individual shares with them things they never share with anyone else. So I really want to stress the value of their presence. And again, our Form D and our volunteer program, I talked about that and how it's been impacted with the COVID, but our volunteers are such an essential part of our team. We also offer grief and bereavement services. So even at the end of an individual's life, hospice care doesn't end. We provide ongoing bereavement services for up to 13 months and beyond if someone needs that, and grief support ongoing. So, you know, our bereavement counselors can help individually. We have groups which have had to change, of course, due to COVID. But as we're doing today, we've all adjusted. We're doing the best we can with that. And that is such a huge piece of our hospice team. And again, that education, just that ongoing education from all of our team members. So I'd just like to close with saying that, you know, a hospice, oftentimes people think about hospice as being the end, and hospice is about living each day to its fullest. And it's about providing quality of care and symptom management. And our goal is to maintain a peaceful environment and to help an individual and their family have a dignified death. So I think that's all I have to say. Thank you all very much.
Lisa, that was fantastic. You know, I have been blessed to be involved with a lot of experts around palliative care and hospice, but that was incredibly nicely illustrated, teased out, and you know, I just really feel like it's so in keeping to have people thinking about getting help sooner, assembling their team sooner. And you know, I think you said not only do we need to know us before we need us, we need to do this before you need to do it, right? You know, so whether that's changing your diet or talking to your pharmacist, or, you know, so, you know, to have that call of action of, you know, completing those documents we all need to have on file. And does anyone have questions? I did post a lot of things in the chat that you should be able to download, you know, and we certainly can follow them up with a follow-up email. Just sometimes it's a little tricky on not all emails like all these attachments. Leslie, did you see anything in the chat that was, anyone want to unmute or let their faces be seen? We don't want to hold you up, but we know we could spend a couple more minutes as well. So don't hesitate to ask your question to Lisa or to Nancy. I thought it was really informative. Very, very informative. Anyone have any comments?
It's interesting on Zoom. It'd be so different if we were all in the room together.
I know.
It really is, but it was a lot of information to take in on both. So we understand that you guys are probably still processing it. And we are happy if you want to email us or call us if you have any questions. I know, you know, Lisa would be happy to answer any questions. I would be happy to answer any questions. I know Cindy and Leslie, we're here if you think of them later and would like to say something.
Yes.
Can I ask one question?
Yes.
This is Sheila Monahan. Lisa, I think Cindy asked in the chat about referrals. Could you tell us, there's a specific dedicated phone line, phone number to call for hospice and palliative care questions and referrals? Could you share that with us? And also let us know the referral sources. Can people self-refer for hospice, for family members, for palliative care?
Certainly. We have two numbers. We have 410-822-6681, and that's our general business number that could actually have an individual during the regular workday, 8 to 4:30, be connected with palliative care or hospice, or just ask some general questions. But our 24-hour intake line, which you could use that for any question, is 410-822-2724. Again, that's 822-2724. And that rings into our intake office Monday through Friday, 8 to 4:30. But at 4:30 and the weekends, holidays, we have an answering service, and we as Talbot Hospice have a 3-level tier of on-call. So if you were to call after hours, you would always be able to speak to a nurse. If one nurse is busy, there's a second nurse, and then there's a third person on call. So please know that any question, any referral can come at any time. And certainly our referral sources, I mentioned that oftentimes our referrals come from a physician's office, but they can come from the patient and family themselves. So if I was interested in hospice care for my mother, I could pick up the phone, call Talbot Hospice, speak to our lovely intake coordinator, Carrie Wise, who is fantastic. And if it was after hours, I'd get a great response from either of the nurses I talked to, but I could initiate that referral process for my mom. That being said, we would start to gather information. Mom would has a primary physician, so they would reach out to that physician to gather information. You could call hospice and have no physician. And if we need to come out to the home and make an evaluation informational visit, we'll do that to start the referral process. So, you know, it's as simple as making that phone call. Oftentimes we get referrals from the hospital for patients who have come in and they and their families have chosen the course of hospice care. So we are the discharge plan coming out of the hospital. We get referrals from the assisted livings and skilled nursing facilities where they've had patients that have been on a, you know, declining trajectory, and they reach out to us. But just know you just need to make that phone call and we will help with the rest of the way. Gathering information, making calls for the patient and family, and doing our best to find what aspect, what model of care is appropriate for the individual. You know, maybe someone calls for maybe I made the call for hospice and find out my mom's not really ready for hospice, but we could then offer you our palliative care team to, you know, start that supportive team approach. And then when my mom's ready, we can make that nice transition from our palliative care program and the pathways assistance to our hospice program. That goes the other way. I do want to say too, that we do have people graduate from hospice. Don't want you to think that you have to worry about being, if you're not, you know, if appropriateness isn't right, we can make the other referral. Or if someone gets better and maybe they don't meet the criteria for hospice for dementia and Alzheimer's, it happens sometimes because maybe we get a referral post a, you know, recurrent infections and a person's really declined. Oftentimes when hospice comes in, doesn't matter what diagnosis, they get better for a while. Just having that team support. But if that happens for an extended period of time, then we could then look at graduating from hospice, but going to back to the palliative care program. So you never lose that team support. So just remember the number and share the number. Yeah.
I just wanted to say, I put in the chat that I think we busted some myths today, you know, about, you know, hospice is just for, you know, is taking away care. You know, I don't want to admit that my loved one might be at that stage. So I don't, I'm not ready to do that, where really we saw all the value add that happens with palliative care, with hospice care, with calling the helpline, with knowing that you're not the only family managing, learning to manage this diagnosis and learning to anticipate, what might be down the road, and also appreciate what is going on, right? So I think there are a lot of myths out there, and by connecting with other people who are in the same world, you can help understand, what's right for your family. And also, as Nancy pointed out, do connect with your pharmacist, make sure that you're taking the medicines as they should. And if you don't think that's taking it right, maybe there's a modification just, with food, or not this kind of food, or, and that might make the difference. So don't be afraid to befriend your pharmacist, and of course your nurses, and utilize the helpline as much as you'd like. We can't do anything without you guys. So thank you so much for spending so much time with us today.
Thank you.
Mia, thank you for inviting us to join with you on this journey. Next month, we'll be having the same kind of setup with an attorney from town, Lee Gordon, and a financial expert. And we're going to talk about the legal and financial implications that you need to be kind of thinking about. And the last month, we're going to talk about communication and get into a little bit more of the caregiver
caregiver's point of view.
Caregiver's point of view and things. And then on May 11th next month, I did put it in the chat, we're doing a cruising through caregiving with effective communication. It's going to be a Zoom with Jennifer Fitzpatrick, who's fantastic, and Jennifer Schermerhorn, professor of social work from SU. So look out for that one as well. Don't be a stranger. I did email you all, so please feel free to email me back. I can't, if it's my personal one, I'll forward it over. Don't worry about it. And my cell phone is there too. So call and ask any question.
Go ahead, Gretchen.
Oh, thank you. The May and the June of these, do you have the dates for those yet?
Yes.
May 19th.
Yep.
Okay.
And June 16th. We decided on the third Wednesdays.
Third Wednesday of each month.
Same time, 11 a.m.
All right.
to 12:30.
Thank you. That's all I needed.
Thank you all for coming. Have a good afternoon.
Thank you.
Thank you so very much.
Thank you.
Leslie,
Bye.
thanks for your help. It was nice to see you today.